chronic obstructive pulmonary disease. So COPD includes both emphysema and chronic bronchitis, and it is actually the third leading cause of death in the United States. Typically, they're going to occur in middle age and almost exclusively are caused by cigarette smoking. It contributes 85 to 90% of COPD deaths. Other causes can be secondhand smoke exposure, occupational exposure, air pollution, things like that. And occasionally, very rarely, emphysema can be caused by a genetic disorder that has a deficiency of a lung protein. Even though emphysema and chronic bronchitis have different features, most patients with COPD have some degree of both diseases, and one of them being predominant. The difficulty breathing is caused by this progressive destruction of the lung tissue, which will either decrease the diameter of the small airways or loss of elasticity in the small airways, and then the obstruction because of inflammation and increased mucus production and decreased alveolar surface for gas exchange. Some of the other things that you may see with your COPD patients is chronic hypoxia leads to clubbing at the fingers. So what's happening there is the capillary beds will actually increase their growth, trying to increase this oxygen delivery. Sometimes in later stages of COPD, they've become accustomed to having increased levels of carbon dioxide, which is normally our stimulus to breathe, so they actually revert to another respiratory drive of low oxygen levels called a hypoxic drive instead of a high carbon dioxide level. So in your patients with chronic bronchitis, the mucus producing cells in the bronchi are increased in size and produce more mucus than normal. So this is what gives us that smoker's cough. And destruction of the cilia, the little finger-like projections that line the airway, make it more difficult to get rid of the mucus. And it also allows bacteria to become trapped in the lungs. Normally these cilia are helping filter this out and get rid of this excess stuff. But after a while, they'll actually kind of lay down and change form or shape or size. Most often the patient who has COPD is going to be stable for long periods of time, but they'll have periods of decompensation or acute exacerbation. A lot of times there'll be an underlying infection that causes this acute exacerbation. Most of the time in EMS, we are called when they have these acute exacerbations. So chronic bronchitis is characterized by a cough that produces sputum, which is just the crap you cough up when you've got a cough, for a total of 3 months during 2 consecutive years. A person who has chronic bronchitis typically is going to be over 50 years of age, and as the disease progresses, they may take on kind of what we call like a classic appearance like blue bloater. They're going to become cyanotic during these exacerbations, and they're, like I said, prone to the right-sided heart failure, which leads to your peripheral edema. During the acute exacerbations, the cough may become more frequent and more productive. There could be a change in how the sputum looks. Wheezing can occur due to the bronchoconstriction, and patients who have this chronic bronchitis are prone to hypercapnia, which can lead to confusion, headaches, drowsiness, altered mental status. Now, your emphysema patients are going to have excessive destruction to the walls of the alveoli, which is going to decrease your surface exchange or your surface available for gas exchange. Because they also have chronic hypoxia, the body is going to compensate by increasing the red blood cells to try to carry oxygen. And so this increased red blood cell level allows the patient to have good skin color even though they may be short of breath. And the classic presentation of this patient is usually called a pink puffer. Now, patients who have emphysema are also prone to acute exacerbations like your bronchitis, and these may be triggered by exposure to smoke, cold air, or other irritants similar to asthma. During these acute exacerbations, the level of respiratory distress increases, your airways are going to narrow, resulting in wheezing. Your patients with emphysema tend to be thin with well-developed accessory muscles because they need that help breathing. And as this disease progresses, they actually will have air trapping in the damaged alveoli, which can give them a barrel-chested appearance at times. People with emphysema also tend to have pursed lip breathing, and what this does is it increases the resistance to expiration, so it keeps pressure in the lungs longer, so it gives that peep. In both types of these disease, bronchitis and emphysema, patients' quality of life can be really affected. Both diseases are progressive and not easy, they can't be reversed. In mild cases, they may suffer dyspnea with exertion, but as it progresses, it may become more frequent and more severe. Some of your more common complications with COPD are pneumonia and spontaneous pneumo. A lot of times patients will be prescribed your corticosteroids or anti-inflammatory drugs. At the paramedic level in most places, you're allowed to give corticosteroids to help with these acute exacerbations, but at the advanced level, usually you're not going to have your corticosteroids. They will usually also have a long-acting bronchodilator, beta-2 agonist, and what this will do will help dilate the bronchioles. A lot of times with these acute exacerbations, they may be treated with antibiotics if that's the underlying cause. But at this point, patients may start to rely on supplemental oxygen part of the time or even all of the time. Their overall goal, SpO2, may vary depending on their physician and their overall health, but it's usually going to be lower than our typical EMS threshold as far as their acceptable levels. It just depends on that physician and their patient's presentation. So the goals for us in pre-hospital treatment are going to be to improve ventilation and improve oxygenation for both of them. So the first thing we do is ensure they have an open airway and see if they need a CPAP or BVM assistance ventilation. Make sure if you do use a CPAP or positive pressure ventilation, this is going to increase your pulmonary pressure in a weakened lung tissue, which could lead to a pneumothorax. So make sure that you're following protocols and checking your pressure settings or your CPAP indications there. All right, follow your protocols when giving supplemental oxygen to patients with COPD. There is some evidence in some studies that even short-term, 45 minutes administration of high-flow oxygen worsens hypercapnia and acidosis in these patients. If available, use humidified oxygen. This is going to help prevent further thickening of the mucus in the airways. And if you have long transport times or doing an interfacility transport, you may want to look into a Venturi mask set at specific oxygen flow rates. Our sympathetic beta-2 agonists, say albuterol, can be used to treat these bronchoconstrictions in patients who are wheezing. And in some places, you may be allowed to use a combined beta-2 agonist and a parasympatholytic agent like ipratropium instead of just albuterol. With that mucus in the lungs, that's obstructing the bronchi, a lot of times that saline that's used to nebulize the bronchodilators can help expectorate that or get it out of there. And so if you have the ability to do humidified oxygen, that is preferred. Hydration with your IV fluids can also help decrease that mucus plugging, but keep in mind, a lot of times your patients with COPD are more prone to heart failure and fluid overload. So make sure that you are assessing very well and checking with your medical direction to determine the rate of fluid administration. And when you are giving these fluids, make sure that you are reassessing the lung sounds frequently for the development of crackles or rails.